paper, Microbiology 2017 exam. So question number 26. The following fungi are responsible for endemic fungal infections. Endemic fungal infection. Cryptococcus neoformans, Histoplasma capsulatum, Fonsesia pedrosi, Paracocstidios brasiliensis, Blastomyces, Dermatidis. Please understand these are fungi, so even the kind of pronunciations, also I've got some tribal tongue. Okay, anyone that can help us here? Which ones are endemic fungi? Uh, anyone? Crypto and which one? Okay. Anyone else that wants to add something? Anyone? So I was trying to read, and what I saw was histo. Okay, thank you so much. Yeah. So from this year's notes that they gave, when you are talking about endemic mycosis, also known as pathogenic, these are the ones that are causing infection that are always there in the environment. They can cause acute, most of them they cause pulmonary infection that can either be acute or chronic. The acute pulmonary infections are normally self-resolving. The chronic, those that cause chronic infections, they can as well cause informations that are disseminated will be out throughout the body. And when you look at endemic mycosis, these guys, most of them, one thing you need to know is that they are dimorphic. Most of them dimorphic. They are going to appear both as a mode, and mode, they appear as mode in the environment, and if they are inside the body, they are going to be appearing as yeast. Some of them they appear as a sphere. So this is RULE. You are going to see one that appear like that. That is in the body. So nearly all of them are dimorphic, but I've not said they are all dimorphic, because you have got one guy which is a good guy. It is not dimorphic. Is that aspergillosis, as aspergilla. And one thing that we need to know about these guys, so there are three which were mentioned as being part of those that are responsible for the endemic infections, and then one which is opportunistic, but it can as well most of the time cause endemic infection. So there is the histoplasma capsulatum, there is the blastomyces, and then there's also the coccidioides. I don't know how you pronounce that. And then there's also the crypto. Now crypto is opportunistic, but it is also mostly going to cause these endemic infections. So that means that the answers we would have picked would be crypto, neoformans, histoplasma, capsulatum. There is also the blastomycetes, dermatidis, and then of these two, they were not part of what was mentioned. So that's why we can leave out those two. Are we okay there? I hope we are fine. Okay. Question 27 concerning endemic fungi. Almost all are dimorphic. Penicillium Manefi infection is an early indicator of HIV infection, South Asia. The diagnostic stages in tissue specimen are fungal hyphae, may often cause disseminated infection in the immunocompromised, can cause infection in both immunocompromised and immunocompetent. Now, let me just pick one and then so that we can be able to answer this question well. Let's pick the histoplasma. The histoplasma capsulatum. So it is going to cause an infection which is known as histoplasmosis. Remember, it's an endemic guy. So what is the cause of histoplasmosis? It's there is a hand. Sorry if okay, the screen is being shared. I don't know. Are people able to see the screen? Just not clear. How about okay? So hope we can see. All right, thank you so much. So we want to mention something about the histoplasmosis. So histoplasmosis, the causative agent is histoplasma capsulatum. Now the histoplasma capsulatum, as we have mentioned, most of these endemic mycosis, they are found in dimorphic form. So they can be found as mold or as yeast. So for the mold is going to produce macro and micronidia. Okay, nidia. And then for this one, which is in the yeast form. Now, you know the yeast is the form that you find in human, isn't it? So this one is going to be inhaled into the alveolar. So that is one thing we need to know about that. And when you talk about conidia, the, these fungi can be able to, they can form spores. So if you see the word spore and those that form what is known as conidia, is the same. Conidia, conidia and spore is the same thing. Just like when we say mold and hyphae, it is also the same thing. So we are saying that the mold guy is producing macro and micro nidia. That's not conidia, nidia. And another thing that we need to know is that their histoplasmosis is going to occur as an acute or chronic pulmonary disease. Now, it can as well be disseminated disease. It can either be acute or chronic, which can also be disseminated like throughout the body. These infections with us, if we are just fine, they are normally going to be not that bad because our body will be able to contain them. But the infections become worse in the immunocompromised. And the best treatment for this guy, histoplasmosis, is going to be amphotericin B for disseminated infection. But if the infection is mild, you are going to give what is known as the itraconazole. We are going to talk about this a bit later on when we reach to those questions talking about antifungals. Another thing you need to know about histoplasmosis is that this is a histoplasma capsulatum is facultative intracellular parasite. It doesn't have a capsule and it is going to affect the reticuloendothelial system. You know, this is the system that defends us, like the spleen and these other, the bone marrow and that. I think that's what I can mention about it. Okay. So it is going to be found in the soil. Birds, let's say birds, when they are moving, they can be able to, when they produce the excreta, the feces, they are going to drop it in the soil. So it will infect people like farmers. You know, they are farming and they are barefoot. So it will be able to infect them. It can especially in the immunocompromised, it can result in chronic cavitopulmonary histoplasmosis. So we can answer the question since we have said at least something on one of the endemic guys. So concerning endemic fungi, almost all are dimorphic. What do you think about that option? Is it true or false? Okay, remember this one is saying almost or, isn't it? Not really or, but almost or. And we have said that most of the endemic mycosis are dimorphic. So this one is going to be true, isn't it? And then for B, Penicillium manifae infection is an early indicator of HIV. True or false? Okay, this one is false. I've maybe you've come across where it says so, but most of these infections, of course, they are going to be related to HIV because HIV people are, especially like the Cryptococcus neoformans. Someone has got crypto. I want also to test for HIV because normally the infections affect the immunocompromised. But specifically for this one, this being an early indicator of HIV, not too direct like that as an early indicator. So if someone, most of those who are going to have these endemic infections, you expect them to be immunocompromised, and one example is HIV, but really not that is an early indicator. The diagnostic stage in a tissue specimen are fungal hyphae. What do we think? Is this true or false? What do you find in the tissue? Is it the hyphae, or the hyphae is the same as the mod, or the hist? Anyone? True or false? Which one do you find in the tissue? Mod or yeast? And is the hyphae guy the hist? Remember hyphae, this is the one that is having the hands. So, so, so that is false, isn't it? And then D may often cause disseminated infection in the immunocompromised. How about that one? This is true, thank you. And then how about E? Can cause infection in both immunocompetent and immunocompromised people. Anyone? Pardon? Doctors, let's contribute. I'm not getting, I don't know if that is true or false. Let's see. Okay, this is true. So, in as much as the infections are worse in the immunocompromised, it can as well occur in the immunocompetent. The next one, the following are true concerning Cryptococcus neoformans. Cryptococcus neoformans is an indicator of HIV/AIDS disease. True or false? Anyone? What do you think about option A? Okay, no, actually, for Cryptococcus neoformans, this is one that you need to know associated with HIV. Most of the majority of the times when you see someone that has got Cryptococcus neoformans, they have got HIV. So that's why they use it as an indicator. Even for the diagnosis, when you diagnose someone with Cryptococcus neoformans and they don't know their HIV status, you are supposed also to test for their HIV status because 90% of the time they are together. Option B, it can cause both symptomatic and asymptomatic infection. True or false? Anyone? Thank you so much. This is true. For these infections that are endemic, like if you are immunocompetent, you are going to have the fungi, but then it is not going to cause symptoms. For the immunocompromised, that's where more of the symptoms are. And then see, the optimal combination therapy for meningitis infection is amphotericin B and the flucytosine. True or false? Anyway, this one you need to know. I'm going to mention it also when we reach to those questions which have to do with anfungals. For those who have got meningitis, specifically cryptococcal meningitis, you are going to treat them with amphotericin B with the flucytosine. Will know also will revise their mechanisms of action. And then for D, meningitis infection can be confirmed by screening the patient's blood for Cryptococcus neoformans. True or false? So the doc says false. Why do you think so? Why do you think false? Why do you think false? Or anyone that wants to help? You know, if we fail to answer the question why, it means that we are guessing. And it is going to be a bit tricky in the exam because if I'm guessing, if any change happens, I'm not going to be able to answer. That's why for every question, even if the answer is very easy, I always ask for the why. It's very, very important. Anyone that wants to help us, D is false. Why do we think it's false? Oh, thank you so much. So we can see meningitis infection can be confirmed by screening the patient's blood. So you actually use the CSF instead of the blood. Thank you so much, Doc. And then E exists in mode form in tissue specimen. Is that true or false? We are just from answering this question at on top. It's false. Remember we said tissue, it's the yeast form. 29. Aspergillus species. So just one thing we need to know about Aspergillus species. These guys, you have got two species. You have got Aspergillus fumigatus. You also have, these are not the only ones, but at least important for this thing I want to mention, Aspergillus flavus, fumigatus flavus. So for the fumigatus, this guy causes an important condition known as allergic bronchopulmonary aspergillosis. So when you have got the Aspergillus fumigatus in the body, specifically you are inhaling it, it is going to go to the respiratory system. That is going to stimulate the our white blood cells, and that is going to result into an allergic reaction that's known as allergic bronchopulmonary aspergillosis. Besides that, the Aspergillus fumigatus also causes what is known as an aspergilloma. But for this guy, Aspergillus flavus causes the cancer in the liver. So hepatocellular carcinoma. That's one thing we need to know about it. Okay, now that we at least we've said something about them, we can go to the questions. Aspergillus species A can cause disease through production of mycotoxins. True or false? Anyone with an idea? Thank you so much. So this is true. Thank you so much, Doc, for that nice contribution. So the same as she has said, the hepatocellular carcinoma, we are having the toxins being produced. You know, allergies are against the organism. And then for option B, may cause disease through tissue invasion. True or false? Anyone? So besides the toxin, disease can as well come through the invasion, the actual guy. Like, you know, this guy, we say that it is as well causing allergic bronchopulmonary aspergillosis and an aspergilloma. So this guy is actually going to the respiratory system, invading the respiratory system, and that is causing disease. So that is true. And then for option C, may cause disease by inducing hypersensitivity reaction. Anyone? Any thought, Doc, why you think it's true? Thank you so much. Thank you. Basically, that. Yes. So the Aspergillus fumigatus is the one that is causing allergic bronchopulmonary aspergillosis, and that is basically an hypersensitivity reaction, isn't it? An allergy is an hypersensitivity reaction type 1. Yeah. And then we have got D. Laboratory cultures often give false positive or false negative results. Any thought on that one? And I know we know that most of the laboratory results will give us some false positives and negatives. Because when you are growing one bacteria, most of them they have got the same features. So as you are growing one, at the same time, some of them we know of all the number of bacteria, fungi that we've looked at. Some of them they resist to these laboratory cultures and the methods that we are using to test. So simply because your culture came out negative doesn't mean it's really negative. And some of them simply because it came out positive. I remember when we were in the corona period, when they were doing this thing for someone mentioned to say they even got that fruit, a pawpaw, and tried to test it for corona, and it was positive. So anyway, whatsoever. So the thing is that you can have those false positives and false negatives. And then for E, preferred first line of treatment is voriconazole and not amphotericin B. True or false? Thank you so much. This is one thing you need to know about aspergillosis. V, voriconazole is a treatment option. The amphotericin B, you are using it for most of those guys, the endemic mycosis. I are going to say when we talk about the classification for and fungos, you will see which ones they treat, but take note of aspergillosis with the voriconazole. And then question 30. Dermatophytes include the following fungi. Now, dermatophytes. Anyone that knows anything about dermatophytes, just anything to help us before we can even look at the question. Anything. Anyone? Okay. So when you're talking about dermatophytes, these are you know mycosis or fungi can cause Superficial infections, mucocutaneous, they can cause even disseminated infection. So all these, even from the word dermatophytes, these are causing infections of the dermis, the skin, right? And you classify them basically into three main ones. You are going to have the microsporum, microsporum, and then you also have what is known as trichophyton. You also have what is known as epidermophyton, like the epidermis. Epidermophyton. You can see the ending in phyton there, except the first one that is ending in sporum. So these three are the major classifications. And this one, the epidermophyton, causes infection only in human. The other two can cause infection also in animals besides human. And these guys, what they do is that they're actually known as keratinophiles. They love keratin, and you know keratin is a protein that is found in structures like hair. So what they do is that they are mod in nature. They are going to come and attach to air. They are going to produce proteolytic enzymes, and then that is going to lead to hair loss. At least that is one important feature that has to do with the infection of these dermatophytes. And besides that, they cause a circular lesion. So we're going to see a lesion like this. And then at the center, there is going to be healing taking place. So you call that as a ring worm. So initially, ringworms, these guys that we see in the head, if say here, I don't know how you call them in Nyanja. So these guys were initially believed to be caused by worms. That's why even the name. Actually, even the word tinea. Tinea means worm. So you are going to see infections caused by these guys. You are going to be seeing tinea in front. For example, uh, the infections caused by these guys, you are going to see tinea pedis. The way you name them is you put tinea and then now you look at the place they're affecting. Like tinea pedis, this is also known as arthritis foot. Arthritis foot, actually. Arthritis. So we're going to see when you look at the foot, nafshuburuka, you, how do you say that in English? Anyone that can help me with the English there? The skin is peeling off. That is the tinea pedis, arthritis foot. You also have what is known as tinea crudis, and this is known as a joke itch. And you also have what is known as tinea capitis. That is the scalp ringworm, the same thing that we used to suffer with very much with when we were children. So when you are talking about the treatment for these guys, you can, for a local lesion, you can just give drugs that will act locally, like miconazole and also the clotrimazole. Those are local antifungals. But if the infection is widespread, you want to give systemic antifungals. And one of the systemic will include things like the I, it starts with I, traconazole, fluconazole, even the common ketoconazole. So to just give a summary, when you are talking about infections caused by fungi, you can talk about subcutaneous infections or subcutaneous mycosis. You can talk about cutaneous ones. You can talk about superficial mycosis. So the cutaneous affecting the skin, they are the ones caused by dermatophytes. So for the superficial, superficial is also the skin, isn't it? But the superficial can also include hair. So these superficial mycosis often exist as part of normal flora, and they do not elicit an immune response like the others. When there's an immune response, we're trying to fight them. So the superficial mycosis are limited to the very last layer of the epidermis, stratum corneum. And of this, it's important for me to mention this because we are going to meet some other questions down. So we just mention it once and for all. Please don't forget what I'm rubbing. So on the superficial mycosis, we can divide them into four. Number one, we have got those that are going to cause what we call tinea vesicolor there. So tinea vesicolor. Now tinea vesicolor is caused by what we call Malesezi fafa. This guy here, Malesezi fafa. That's the one that is causing the tinea vesicolor. So this condition, when you look at someone, like if someone, a patient comes to you, you are going to see on the body they have got pigmentations. At one part they have got a patch. It can either be hyperpigmented or hypopigmented. That is it. Just think of the color there, right? Vesicolor. Okay, you are going to see these hypopigmentations and hyperpigmentations on the skin. The second one, superficial mycosis, is tinea nigra. Now, the tinea nigra, these are painless, black, and non-scaly patches. You are specifically going to see them on the sole of the feet or the palms of the hands. Now, if I say palm, it's just palm, right? Do we have palm of the feet? Okay, so basically that tinea nigra is painless and they are black. They are not scaly. They are patches on the palm or the so they are black. Don't cause pain and they are not scaly. And what causes this is known as the Hote Wernicke. So there is Wernicke there. You just remember Wernicke syndrome. And then Wernicke's aphasia. There is also what is known as PIDRA. Now, PIDRA, this is a nodular formation of hair shaft. It can either be white or black. Okay, a nodular formation, like it's a nodule, like something that comes out of the skin. It can either be white or black. But one thing I want you to take note of is that the black one is as a different cause, a white one has got a different cause. So for the black is caused by what is known as the PIDRA hote, like the one you can see on top there. And then the white nodular lesions, these are going to be caused by what is known as Trospora begeli. Trospora begeli. Okay, so those are the basic things. The fourth one I mentioned there, for the fourth one, they are the dermatophytes. They are also causing superficial infections. So those are the things. Okay. So back to our question. Dermatophytes include the following fungi. A. Trichophyton. Is that true or false? So the dog says true. We all confirm true? Okay. And then Trichosporon begeli, which is this thing I was trying to say here. Others write it as Trichophorans. That's false. Male, Malassezia fafa. That's false. Microsporum. That's true. Epidomyphyton. That's also true. Thank you so much. And then question 31. In superficial fungal infection, A, Malassezia fava is associated with hyperpigmented or hypopigmented skin. True or false? So that is true. White fungal infection, often seen under the armpit, is due to Pedria horte. Yes, I've seen a hand. Is my network breaking? Okay, before we continue answering, is my network breaking? Okay, thank you. So white fungal infection often seen under the armpit is due to Pedria horte. Is that true or false? Anyone? So remember, the look at this one. The white is caused by Trichosporon begeli or bigeli. The black is the one that is caused. Yes. So this is white. So the white one is caused by the Trichosporon begeli. And then the black is caused by the Pedria horte. So this is going to be false. And then C, Malassezia species is associated with dandruff. True or false? True or false? So dandruff. This is the same we are calling as tinea capitis. So this infection, these are the Malaysia fafa is affecting. Besides it, we talked of it as causing the hyperpigmentation and hypopigmentation. That is specifically on the general body. That is on the general body. Now, how about if it goes to the head? What do we expect it to cause? Because on the body where you are not having hair, it's causing the hyperpigmentation and hypopigmentation. How about if it is in the head? Hope we get that. Okay, so that is going to be false indeed. So we are saying the Malaysia species cause hyperpigmentation and hypopigmentation. How about if they went in the head? So it will still be the same thing we're talking about, isn't it? The hypopigmentation, not the dandruff. And then D, 10% potassium hydroxide preparation of skin scraping are often sufficient for the diagnosis of superficial infection. True or false? So what happens is that Ye- yes. So for superficial infection, like let's say this is the part of the skin affected, you can simply take a scrap there, and then you are going to use the potassium hydroxide 10% for diagnosis. So that's true. Tinea nigra is characterized by brown to black macule, usually on the palms of sores. True or false? That's true. Thank you so much. And then number 32, number 32, chromoblastomycosis. So we are now talking about chromoblastomycosis. Let me just mention something about it before we can even go on to answer the question. One thing you should think about what comes to your mind if you hear chromo? Chromosomes? Besides chromosomes, anything that comes to your mind? Like if you hear chromatophilic, It's also color, right? Yes, thank you so much. So this chromoblastomycosis is a subcutaneous infection caused maybe because of trauma. And what is going to cause, which fungi are going to cause it? So you have got number one, what is known as for why am I writing so badly? Okay, so there is the Fonse, I don't know how to pronounce this. Fonsesia, that's one fungi. Number two that can cause is Cladosporium. And then number three that can cause that is Fulafora. Now, these guys, they have got one thing in common: the Phocesia, Cladosporium, and Filaphoria. They are known as dermatosias, not dermatophytes. Not the dermatophytes we mentioned. Remember, we mentioned the dermatophytes already, and we are done with them. These are known as dermatosias fungi. And the reason as to why they are called that is because they actually, in all their forms, these are dimorphic fungi. Whether they are in form of a spore or as a mold, they are dark. That's why they are not like that. They are dark. So these guys are actually soil fungi, and they slowly progress. If the infections that they cause is a granuloma like infection, like a wart lesion. We know a wart, what? So that's something we can know about them. So chromoblastomycosis A is a fungal infection due to Umphocesia pedrosoi. Whew, after reading you're supposed to breathe properly. Is that true or false? So that is true. True, thank you so much. And then is characterized by early smooth papule that later have large wart-like appearance. How about that one? Is true. Is it transmitted through aerosol? Did I mention these guys are found in the soil? They are going to mostly affect farmers, those who, they are coming with their foots just there, and then they can now enter because they're found in the soil. So it's transmitted through aerosol. True or false? So you know what happens because these guys are found in the soil. You are walking. Here is your leg. They are going to come and this leg. They are going to come and enter, penetrate this leg. Besides them causing the wart-like infection, they can enter the lymphatic system, right? So let's look at C. Is transmitted through aerosols. True or false? That's false because we are just saying that they are found in the soil. May develop in elephantiasis. True or false? True. Because we've just said that they are going to enter the lymphatic system when they enter. Treatment of choice is itraconazole. True or false? Remember we said that itraconazole, ketoconazole, fluconazole, those are systemic antifungals and they are good. If something is entering the lymphatic system, that's a systemic, so you need something that is strong enough. Okay. It is recommended that uncomplicated bacterial urinary tract infection can be treated with effective antimicrobial agents that have got low renal threshold. Antimicrobial agents with low renal threshold include basically what? Antimicrobial. So low renal threshold means that they have just with a little concentration, they can be they can go to the urinary system and there they can be excreted. And you want these drugs to be excreted, to be easily able to go to the renal system to undergo excretion, right? Because this is UTI and you want something that is going to reach as far to the urinary system. So basically, the question is which one of these drugs, antibacterials, can you use to treat UTI? Norfloxacin, tetracycline, chloramphenicol, erythromycin, nitrofurantoin. Anyone? These ones, they are specific ones that you just need to know, like the norfloxacin, erythromycin, and the nitrofurantoin. These antibiotics, specifically for UTI, they are good. You can, when you check through the notes, you actually find them. In the next class, we'll see some more questions and talk about more antibiotics. For today, we won't waste much time on antibiotics. We'll talk more about antifungals. Bacterial urinary tract infection. Now, here is this is our kidney here. And what I'm putting here, this is the prostate. I'm putting the male. This is the male urethra. So you can see for, because when you look at UTI, the major cause for UTI. Anyone to help me? Which organism is the major cause of urinary tract infection? Anyone? The microorganism which is the major cause. Thank you so much. The E. coli. And E. coli is actually normal flora of the GIT. And you know the GIT, like the anus, is near to the reproductive system, more especially for females, the urethra. So what happens is that those bacteria can move from the anal canal coming into this. But that's why when you are cleaning the genitals, you clean anterior to posterior, because the urethra is more anterior. It's on top, depending with how you are looking at. Yeah. So infection up to this point, this region is known as lower urinary tract infection. But up here, going to the kidney, that is going to be upper. So lower urinary tract infections can go also into upper urinary tract infections. So specifically the one that is caused by the bacteria, these UTIs, and more especially the E. coli. So when you get the bacteria, you want to be able to diagnose the condition. You want to take the midstream urine. You know that one, you ask the patient in the morning, they urinate, they pause, they urinate in the bottle, and then they finish. That's the one you take. So if you see in that midstream urine greater than 10 to the power 9 bacteria per mil of the urine, that is diagnostic of UTI. Please, it is midstream. But then, not suprapubic, not any other method, midstream. If you find less than like 10 to the power 3, less than, but then the patient is also symptomatic, that can also be diagnostic, okay, of the infection. I think that's enough. Bacterial urinary tract infection. A. Urine is established with the presence of 10 to the power 9 or more bacteria per mil or for voided urine. Supposed to be complete there. True or false? Anyone to help with that? True or false? So for A, it's 10 to the power 9. Uh, when I was typing the paper, I just left out that number. So this is true. And then B may be indicated by 10 to the power 3 or more bacteria per mil of voided urine in symptomatic patients. How about that one? Because these guys are symptomatic. So 10 to the power 3, yes, is going to be diagnostic, 10 to the power 3 or more. And then C of the bladder can be best diagnosed by culture of terminal portion of urine. True or false? Anyone? Why do you think false, Doc? Any thought why? Yeah, thank you so much. So you get, remember the bladder. The bladder is a lower tract part. So you get a midstream, not the terminal portion. And then of the bladder may be indicated by growth of a single colony from suprapubic aspirate of urine. How about that one? Why do you think so? Okay, that was specifically, look at this. That was specifically we are counting, like you are counting the bacteria when you take that mainstream urine. And when you find you have got more than 10 to the power 9, that per mil. But this of the bladder may be indicated by growth. This is culture of a single colon from suprapubic aspirate of urine. So that's also true. Commonly due to Escherichia coli. How about that one? That's true. Organisms commonly implicated in water and foodborne diseases include hepatitis A, Campylobacter, rotavirus, Escherichia coli, Cryptosporidium. Let's start with A. Is that true or false? True. Remember, for hepatitis, you have got A, which is orophycal, and then B and C, those are blood hepatitis, guys. They are transmitted through the blood. And then Campylobacter, true or false? Is also true. Rotavirus, anyone who knows about it, is also true. E. coli is true. Crypto is true. Actually, when you look at the list for diseases that can cause waterborne, just waterborne infections, it is an endless list because it's ranging all the way from viruses to bacterias to parasites to protozoa. There are a lot that can cause these water and foodborne infections. The following foodborne pathogens produce heat labor or enterotoxins. Enterotoxic E. coli, Campylobacter species, Vibrio cholerae, Staphylococcus aureus, Streptococcus pyogenes. Let's start with A. We want those which produce foodborne pathogenic, which produce heat labor enterotoxins. Enterotoxigenic E. coli. How about that one? Any thought? Any thought on that? Let me mention something about E. coli that might be of help. When you are talking about the infection by E. coli has got different species, a lot of different species, and they have got different features. So if we start, we are going to have like, is it 5 or 6 species for the E. coli? So number one that we can talk about of the species is you have got those which are invasive. They invade. Remember these E. coli, specifically, I'm explaining this talking about diarrhea. Okay, those that can cause the E. coli that can cause diarrhea. So there is what is known as entero-invasive E. coli. Even from the word entero-invasive, you know the GIT is lined by these cells which we call enterocytes. And the enterocytes, they have got villi. You can see they have got villi here. So for this entero-invasive E. coli, what it does is that it invades. To invade means to penetrate through. It will be able to penetrate through the enterocytes. And if it does the penetration, another thing that you need to know about the entero-invasive E. coli is that it's actually atypical from the others, because normally the E. coli you are going to see that it is mortal and those other features that we can mention. But this guy, the entero-invasive, is actually atypical, number one, and it is also non-lactose fermenting. The features of E. coli, they are gram negative, they are also hemo- hemolytic, okay, actually beta hemolytic, they are mortal, they are bacillus, they are also mostly capsulated, mostly. You can have some which are not. They are also urea negative when it comes when you are performing the urea test. Besides that, they are also lactose fermenting on McCock agar. So because they are lactose fermenting, they produce carbon dioxide. That's another thing. Okay, so basically that. So what this guy does is that he is going to be able to enter the enterocytes. If it enters the enterocytes, what it does is that it now starts dividing. And then after dividing, it can go to another enterocytes infecting them. So that's how it causes the infection here. Remember talking about these guys which cause what? Diarrhea. And then the second one that we can talk about is what is known as enterotoxigenic. Even from the way this is enterotoxigenic, let me not mention something that is going to disturb us. So enterotoxigenic is the major cause of what is known as traveler's diarrhea. Doesn't spare any age. Someone went out, they come back, they have got the infection. So obviously you got it from somewhere. The infective dose is also really high, the same 10 to the power 9, and it is transmitted only by contaminated food or water. Please take note, only contaminated food or water. Like someone travel, it's a traveler's diarrhea. You've gone in a foreign land of you've come back. So that's one. And then what are the characteristics of the diarrhea produced by the enterotoxigenic E. coli or just the infection? It is watery diarrhea. The traveler's diarrhea is watery. And then you also have nausea, but the patient is going to have no fever. What helps this enterotoxigenic has got some colonizing. It has got a plasmid, which is the the circular DNA, and also some other colonizing factors. That is what will help it in the pathogenesis or the virulence. Number three, the third type is the enteropathogenic. The enteropathogenic is going to cause non-inflammatory watery diarrhea. Also, the enterotoxigenic was causing watery diarrhea. This one specifically, it is non-inflammatory, and is specifically going to affect children, those who are less than 6 months of age. So to be specific, it causes infection in those people that are less than 2 years, but more commonly in the less than 6 months babies. Okay, so that's about the enteropathogenic. Another thing that you need to know about the enteropathogenic is that how do they cause infection? These guys, they are going to go to the enterocytes. Remember, we said that you have got microvilli and villi. They are going to come and bind here. So these guys are non-invasive. That's one thing you need to take note. They are not like the entero-invasive, which are going inside the cell. These are non-invasive. They'll just be on the surface, and when they attach to the surface, they are going to reduce the size of the microvilli. And because you have reduced the size of the microvilli, that is going to reduce absorption. Since you have reduced absorption, it means, let's say, for example, if it's sugar or lactose, those guys are still going to remain here. So it will start attracting water from the cells, and that is known as osmotic diarrhea. So it causes that osmotic diarrhea. The other one is known as the enteroaggregative. So from the way these are aggregative, same with the enteropathogenic, they are also non-invasive. But then what they do is that they are going to come and attach to the microvilli, forming, you can see the way they attach, and they are going to form a biofilm, like they are forming like a layer on top here. And these guys are responsible for dysentery. What they do is that they produce a toxin. So there is a cytotoxin production. And they also release interleukin 8, which is going to go inside. And that is going to result into the diarrhea. Specifically, these guys cause bloody diarrhea. Please take note. Because these two, they were causing watery. This one is causing bloody diarrhea. The fifth one you need to know is known as enterohemorrhagic. The enterohemorrhagic is rare, and it is also known as sugar toxin producing. So it produces the sugar toxin. Now, sometimes it's thought if someone has got this, if we say sugar toxin, which one are we talking about? Because I'm talking about this toxin produced by Shigella or the same enterohemorrhagic. So please take note. Don't confuse it with because this one has got toxin in it, you think it is the one that produces the Shigella toxin. It is the enterohemorrhagic. Okay. Basically that, and the sugar toxin is going to cause hemolytic uremic syndrome. It will cause dysentery, can as well cause hemorrhagic colitis. So these are the ones here. I think that those are the five. So the following are foodborne pathogens which produce heat stable enterotoxin. Enterotoxigenic. So let's now go enterotoxigenic. What do we think about that one? True or false? Okay, so our doc has said true there, so this is true. Enterotoxigenic E. coli, they are going to produce a heat stable toxin. That's true, of course. It's not a sugar toxin. So we've seen exotoxin is also enterotoxin, but it's heat labile, not heat stable. Just that for cholera, which is the same as enterotoxin. And then, so that's false. Staphylococcus aureus, how about that one? Okay, so true for Staph aureus. Now, how about strep? So strep is not. Thank you so much. It's an exotoxin. And then endotoxin includes, so as I was saying here, endotoxins are those things that are found on the structure of the bacteria. They are part of the cell membrane. So which ones of these are part of the cell membrane? Endotoxins. Is cell membrane or cell or which one? If I've not confused them. Lipopolysaccharide, lipo-oligosaccharide, lipoteic acid, teichoic acid, peptidoglycan. So let's start with the first one. Lipopolysaccharide. Is that an endotoxin? Okay, so endotoxins are found on the cell, yes. The polysaccharide and oligosaccharide are found on the cell. These guys are found in the cell membrane. And specifically, endotoxins are produced by gram negatives, not gram positives. The following is true concerning fever. Production of tumor like TNF alpha improves appetite. True or false? Actually, the TNF affects appetite. It doesn't improve, it worsens it. It's bad. B, it can only be caused by bacterial infection. Fever, it can only be caused by bacterial infection. True or false? False. We know a lot of infections can produce fever, including virus. Interleukin 1 and tumor necrosis factor alpha directly acts on the hypothalamus to induce fever. True or false? So this is not true. Actually, interleukins, when they are produced because of an inflammation, they can cause fever, yes. But they don't directly stimulate the hypothalamus. Instead, they act through some other mechanism. What I was reading is that they are going to affect the prostaglandins. That's when they can cause fever. Excessive secretion of tumor necrosis factor alpha can lead to wasting of the patient. True or false? So that's true. Wh- Pardon, doc? Okay, do you want to give us your thoughts? Why? Thank you so much. I love the thought. So yes, it is worsening appetite. It actually leads to what is known as cachexia, which is wasting because someone is not eating. There's muscle wasting, and that is wasting of the patient. Excessive secretion of interleukin 1 and tumor necrosis factor alpha can cause hypotension. True or false? Any thought? That's of course true. Any thought? Mm. Oh, thank you so much. Nice analysis. So the interleukins, tumor necrosis factor, these guys, when they are released, they are going to result into vasodilation, and that causes hypotension. 39. Zoonosis are diseases of animal that can be contracted by people. True or false? That's true. Includes hepatitis A infection. True or false? Includes hepatitis. Hepatitis A is orofico. Is that part of zoonotic infections? That's false, isn't it? Yes. And then C, poisoning due to fish toxin. Is that true or false? Fish toxins. Imagine just a fish has produced the toxins and then you. So that's C, false. So zoonosis is what is passed from animals. Infection, you have come in contact with animals and then you get the infection, not the product. Malaria. Is malaria a zoonosis? How about rabies? It's true. Thank you. And then plague is a zoonotic infection. Okay. I want to mention something about a plague. You know, uh, in scripture, in the Old Testament, there is a time when the Israelites were, the land of Egypt was struck by plague. And you know what happened? How many deaths happened? This is actually true. It also happened like in the 1300s in Europe, and also like between the 1800s up to that was showing 19 something 1959. So a plague had to eat the place, and Europe specifically. And the problem is that they didn't know the cause. So what happens is that these people saw a boat coming. They were on an island, and everyone in the boat was dead. The few of those people they saw in the boat that were not dead were really, really bad. And the problem is that anyone that came and you just have small contact with them, whether you touch them or just in the air, you are going to get infection. It is estimated that by then the world population was somewhere 700 million. Over 60% of the world population died because of the plague. That's why they even call it not plague, but the plague. It is caused by Yersinia pestis. It's bad. It's a bad guy. It is fatal. But now the infections are still there even today. They don't have much effect like that now, not because they have become less strong, but the knowledge of science has increased. So we have now known the cause, because then they didn't know the cause. Imagine a boat just comes and then you are trying to be able to help the people, and you don't know what has caused it. Not knowing why you're trying to help them, the same thing strikes you also. You end up being like the people that you are trying to help. So now it is become a bit less bad because we understand the cause. So that is something about the plague. So there are actually three many types of plague. There's what is known as bubonic plague. There is what is known as pneumonic plague, and there is what is known as septicemic plague. Bad guys. These are deadly guys. Okay, let's go. And they are mostly transmitted from rodents. Like what they thought was because in the boats that they saw people who died a lot. When they opened those boats, they found a lot of rats, a lot of those rodents which came out. And it's believed that because those rodents were spreading through and through, and they got to infect people. It's also believed that some of them were spreading through the air. If someone just touches you, you get it. Within the shortest period of time, like up to 2 days, you have got these bad, bad signs and death happens. So it was really bad. You can imagine over 60% of the world population dying. It means that more likely your partner is also gone. You remain single. Okay, the plague is a zoonotic infection. A is caused by ticks. True or false? True or false? It's false. What is the cause if not ticks? The rodents. B is due to Yersinia pestis. True or false? It's true. Of the pneumonic type is associated with high fatality levels. True or false? Are we able to see my screen, others? Okay, others are able to see. Maybe just try to check the network or the bundles. They should be enough. So let's go option C. Of the pneumonic type is associated with high fatality levels. True or false? Okay, that is true. And then D is not prevalent in Zambia. True or false? So it is not prevalent in Zambia. Okay. And then the next option, it's not prevalent in Zambia. It's actually prevalent. You should try to search. What I was reading was like specifically in the southern and western provinces, it is there. It is there, but at least it's not that bad because we have got some knowledge. So that's false. F can be prevented by effective control of rodents in our residential surroundings. True or false? True. Thank you so much. Okay, we've reached to the questions that I want us to talk about something here. Ant fungos. Let me just briefly talk ant fungos. And the thing is this: within 2 minutes, we are talking about both the microbiology and pharmacology. So you will not read the pharmacology part and you just hammer them in the exam, isn't it? So for the ant fungos, let's say this is the fungi have got is the reason as to why they are difficult to treat is because their composition is more similar to us, like human body. The one difference that is important is that they've got a cell wall that we don't have, so we can utilize that. And they also have got a cell membrane. And another important thing that we can utilize is that the cell membrane for these guys are not made of cholesterol like humans. Instead, they are made up of ergosterol. So they are made of ergosterol. Okay, there. Now, this ergosterol can actually come from another structure which is known as lanosterol. And this lanosterol can actually come from what we call squalene. Okay, squalene. So you have got enzymes that do these conversions that we've written here. For you to convert a squalene to lanosterol, you need what is known as squalene epoxidase. Squalene epoxidase. And for to convert lanosterol to ergosterol, you need what we call cytochrome 450, 1 alpha demethylase. The cell wall of these guys are made up of what we call glucan. Plants have got cellulose. Bacteria in the cell, what do they have? And you have got some other animals like insects which contain in the cell chitin. So fungus specifically, they have got glycan. So the drugs that work on this guy, now you also have the nucleus, okay, where you have got your DNA. So this is basically where these drugs are going to be working. And we can classify them into three many groups. The first class of these drugs are going to be those we call polyene and fungos. Number one, the polyenes. Polyenes. Now, polyenes, these guys, the way they work is that they bind to ergosterol, okay, in the plasma membrane. And when they bind to, let's say this is ergosterol, when they bind to ergosterol in the plasma membrane, they'll start forming pores. When they make those pores, it means that water can enter this guy and it will be able to, boosh, it will burst. And you have got two of these polyenes. Number one is amphotericin B, which is a very good guy that we know, amphotericin B. And then in number two, we have got what we call nystatin. So when you look at amphotericin B, this guy helps. So these two guys, both the amphotericin and the nystatin, they are going to reduce the amount of membrane ergosterol. Remember that we said that they bind to ergosterol, right? And when you reduce the amount, that is this is why it is actually a good thing. At the same time, it is a problem for antifungals. You know why? When the when these drugs bind to the ergosterol, we said that they are reducing, right? They are reducing the amount of membrane ergosterol. And when you are reducing the amount of membrane ergosterol, it means that next time you give these polyenes, there is no ergosterol to bind to. And that is what leads to the resistance of polyenes. So there's going to be resistance because of the reduction in the number of membrane ergosterol. Now let's talk a bit about amphotericin B. Amphotericin B, normally you are going to give it together with this drug which we call flucytosine. You are going to see its mechanism of action later. Flucytosine. And they have got this synergistic activity. Remember what we said about synergism in pharmacology? 1 plus 1 is equal to 3. When you combine them, their net effect is greater than the effect of their individual guys. So what happens is that when you give them, they are specifically good when you combine them in candida and cryptococcal infections. You hear of cryptococcal meningitis. Yes, they're actually good. And then for amphotericin B, you are going to give it IV. Okay, you give it IV. And this guy, one thing that you need to know is that it is highly protein bound. What does that tell you? There is poor tissue penetration. So when you want this guy to reach to the central nervous system, like for meningitis, you are supposed to give it intrathecal via the lumbar puncture. Push. That's when it is going to reach CSF. Otherwise, the IV will not be able to help very much. And it is excreted and changed in the kidney. So meaning that whether the kidney is working or not, we don't care because it doesn't affect the excretion of this drug. Another thing that you need to know about amphotericin B is what is known as the shake and bake phenomenon. Shake and bake. Anyone that wants to say something about shake and bake, anything they know? Anyone? Shake and bake? Okay, about the shake and bake, this is the adverse effect that is associated with the amphotericin B. The adverse effect. So what happens is that When you give amphotericin B, uh, in, it can cause fever. When you infuse it in blood, like the infusion, it can cause fever, chills, rigor, and hypotension. Those four things: fever, chills, hypotension, and rigor. You know rigor, like rigor mortis, where there is someone just become, they just contract. They can't permanent contraction. When a body dies, when you use up the last ATP, there's contraction that happens, right? A permanent one. That's rigor. So you can prevent this shake and bake by, number one, before you give the drug, test the dose before IV therapy. You want to see at which level there is response. Number two, you can as well do a pre-treatment before you give the amphotericin B. You do pre-treatment with the antihistamines, NSAIDs, and also glucocorticoids. Okay, and then number three, you can also use what we call meperidine. And meperidine is specifically to prevent the rigor. One thing again you need to know about amphotericin B is that it can lead to nephrotoxicity, and that is the major dose limiting side effect. That's what will make you to give it in small amounts. Besides that, amphotericin B can cause anemia because it leads to the reduction in erythropoietin, and it can also lead to the reduction of potassium, causing hypokalemia, magnesium hypomagnesemia. It can also reduce the glomerular filtration rate. It can as well cause renal tubular acidosis. Because it is reducing all these electrolytes we've mentioned, it can as well lead to arrhythmias because of the imbalance of those electrolytes. So because we say that it causes nephrotoxicity, when you want to reduce the nephrotoxicity, what you do is that you give also normal saline. You can as well combine it with other drugs so that you reduce its dosage. Besides that, you can also use the liposomal amphotericin B. Okay, instead of just giving amphotericin B alone, like more like you put it in a coat. So that's the liposomal amphotericin B. And the importance of the liposomal amphotericin B formulation is that it has got rare, it requires a high dose, and then it has got less toxicity. But the problem is that it is expensive. That's everything you need. That's the pharmacology you need to know about the amphotericin B. So, what kind of infection does it treat? It is a good choice for most of the systemic mycosis, like the one caused by Cryptococcus, Candida, Aspergillus, even this one I failed to pronounce it, cocoidosis, that one, even including other fungi. So it is actually broad spectrum. And then one thing you need to know about nystatin, it has got the similar structure with amphotericin, except you give it topical. Okay, like you apply at the site, specifically for yeast infections and the skin and mucous membrane infections. Okay, you don't give it IV because it is too toxic. That's a problem. It is too toxic, so never give it. So that's the first classification of anfungals. You give the polyenes. The others are really direct and short. So others, we have got what we call, look at this. Can you see the stages here that we can inhibit? So you can give drugs that are going to inhibit this cytochrome P450 dependent alpha 1 demethylase. You have got azoles. And then drugs that will inhibit the conversion of squalene to lanosterol are known as allylamines. Allylamines. Okay. Now for the azoles, if you remember in test, what was that, test 3? You have got imidazoles, which have got two nitrogens. Imidazoles. And you also have those which have got three. We call them triazoles. Triazoles. So for the triazoles, what you need to know is itraconazole. Itraconazole, we've been mentioning it for some treatment. And then you also have fluconazole. You also have voriconazole. Remember, this was the drug of choice for treatment of, if someone remembers, aspergillosis. So, itraconazole, fluconazole, voriconazole. You also have posaconazole. At least these four. And then for the imidazoles, those which are imidazoles, they have got two carbon, two nitrogens. You have got ketoconazole, the very common one that we know. Miconazole. There is also chlortriconazole. So these. So we can now go back to that question and then be able to answer it for this year's test three. Okay. So these are the guys. These, what are they doing? They are helping, at those different stages, the azoles. So the way we classify these guys, basically that. What is the other classification? Basically that they are inhibiting different enzymes. Okay. Take note that ketoconazole specifically is because look at this, they are inhibiting this enzyme. It is present in the fungi, but in our body we also have cytochrome P450. That is why azoles are also inhibitors of the cytochrome enzyme. So that's why these guys have got a lot of drug interactions. Okay, if you can now relate to what we've been saying, all these were for different drugs. No, they interact. Ketoconazole is a liver enzyme inhibitor. Rifampicin is a liver enzyme inducer, and those things. So specifically, ketoconazole has got effect on the liver, can cause liver problems. Also, so ketoconazole liver problems, itraconazole liver problems, also voriconazole liver problems. You have got one that is going to cause kidney problem, that is the fluconazole. Okay, just one. Nothing that you need to know about these guys. They have got widespread distribution after oral intake, so they are good. You can just take them orally. They also reach the cerebrospinal fluid, except ketoconazole. It doesn't do that. Doesn't reach cerebrospinal fluid. And then for these guys that we are calling as the amines, you have specifically, you can divide them in, they end in fine, like nafli fine. You have got it te bina fine. You have got it butena fine. Like they're ending in fine like that. So specifically for te bina fine, this guy will be used for treatment of dermatophilic infections. You know the dermatophilic infections, those we talked about already. And it will be the oral formulation for the terbinafine is going to be used for onychomycosis, and also for the treatment of fingernail infections. That's basically caused by that same thing. So this is how we classify antifungals. Another class that is really not specific, like how do you inhibit? Remember, we talked about the beta glucan. So you have got enzymes, drugs that we inhibit, that we call them echinocandins. This name, echinocandins. And you have got three nice names for the examples of echinocandins, and they end in fungin. All of them which inhibit glucan end in fungin, like caspofungin. You also have anidulafungin. The third one is micafungin, like this MACA, micafungin. How do they work? They are going to inhibit the enzyme which is known as the beta 1,3 glucan synthase. That's the enzyme that produces the beta 1,3 glucan. So they are used for the treatment of invasive fungal infections, Okay, even for infections that are resistant to amphotericin B and to fluconazole, this guy that destroys the kidney. Infections that are resistant to this, you can give these echinocandins. The way they work is that they can either kill the fungi or they can just stop the growth of the fungi. For example, those which are fungistatic, they are meaning that they are just stopping the growth of the fungi. They treat infections caused by aspergillus species. So fungistatic drugs, aspergillus. And then for those which are fungicidal, they specifically treat candida. They will kill candida. They will just kill it. Okay. But take note, you are supposed to use them with caution in liver disease. Please, you use them with caution. You only have now two other drugs which don't have any one of these mechanism of action. And that is now the one which we said, remember we said that you combine it with amphotericin. That is the flu cytosine, and there is this one known as glycofulvin. So these two, flucytosine and glycofulvin. Flucytosine specifically is going to go and disturb cell division. It is going to bind to the tubulin molecules. You know the tubulin helps in cell division, mitosis. So it will disturb that. That's the flucytosine. But this guy is only active against the, oh sorry, no, not that one. I was mentioning something else for flu cytosine. Flu cytosine is going to the active form. This one, it only becomes active when it enters the cell, the inside of the cell, and it is converted to 5 flu uracil. And that 5 flu uracil is now going to inhibit the production of DNA and mRNA. When it prevents the production of the nucleic acids, it leads to cell death. One thing about flu cytosine is that it is well absorbed, it is well distributed in the body, including the CSF. Okay, it's well. But the adverse effect is that it causes concentration related bone marrow toxicity. Depends on the concentration, the toxicity on the bone marrow. So make sure that you monitor when you give this drug. And take note that flucytosine is only active against the yeast, and it lead the action for flucytosine goes to resistance very fast. Efficacy is going to be reduced because of resistance, but then it is less toxic than amphotericin B. It's actually the drug of choice in cryptococcal meningitis. You actually combine it with amphotericin B. Take note of that. And then for the glycofulvin, that guy is the one that will be able to disturb the cell division by binding to the tubulin. And it is only active against the dermatophytes. Only against the dermatophytes. Okay. Just like the other that we mentioned, specific, which one was that? The T butadiene. It was effective against dermatophytes. What else should we know about there? It Greece, your Falvin, has got also hepatotoxicity, and that is the dose limitation that it has, hepatotoxicity. Don't forget the amphotericin B was nephrotoxicity. This one is hepatotoxicity. And the glycofulvin is contraindicated in acute intermittent porphyrias. This is where there is a reduction in the production of heme. So that is everything to know about antifungals, the pharmacology, at least the pharmacology, that's the pharmacology part, and also the microbiology. So just take note one thing about the azoles. For flu, conazole, it is effective against yeast, and it is the drug of choice for mucocutaneous candidiasis and prevention and treatment of cryptococcal meningitis. Prevention and treatment. Remember, for treatment for cryptococcal meningitis, you can also use the flu cytosine, isn't it? With amphotericin B. But this guy for prevention specifically. And then itraconazole, this guy, which is a triazole, is good for sporotrichosis, and blastomycosis. And then the V, the voriconazole, we mentioned it in aspergillosis, invasive candidiasis, and it is also going to cause, just think of V for visual disturbance. It causes a reversible visual disturbance, but that doesn't mean that if the visual disturbance comes, you stop the drug. No, it will stop. It is reversible. And then ketoconazole, it is a common one. You need to know it causes hepatotoxicity. At least that one we know. Okay, hepatotoxicity together with glycofulvin. And so please never use ketoconazole with antacids because it reduces a pH that is high. Like basic pH reduces absorption. So you never combine it with the antacids. That is the basic thing we need to know about this. So we can go now to our questions. And fungos that inhibit cell membrane include, so we can go polymyxin B. Is that true or false? Anyone? Anyone to help with that? Does this guy inhibit cell membrane? Anyone? People, we are just from talking about this. So those which inhibit the cell membrane are those the you have got the azoles, you have got also these guys that are, so amphotericin B, and also which ones? Anything else? Remember also the azoles. They are inhibiting cell membrane because they are stopping the conversion of the lanostero to egostero. The azoles like ketoconazole, fluconazole. But flucytosine, this guy, we saw it was working specifically uh, inside the cell, right? And then this first one is an antibiotic. So we have just like 5 questions to go. And fungos may be classified based on their chemical structure as allylamines. Is that true or false? We've just talked about the classification. So that is true. The allylamines, those which are inhibiting the conversion of squalene to the lanostero. And then imidazoles, that is, yes, imidazoles, that's also true, isn't it? Antimetabolites, that's also true. The antimetabolites, this is the flucytosine and the uh, glycio. Yes, those two, because they are actually working inside the cell, stopping the conversion of the DNA or the production of the DNA and also stopping cell division. Also, the proteins, like these are the ones that are specifically working on the cell membrane, cell wall, right? Inhibiting the glucan synthesis. So the only force guys. Okay. So for 41, it B is true, amphotericin B, and D and E.